Hi, everyone. Welcome to the Men's Health webinar. We're thrilled you're joining us this evening. My name is Ro Kyle, and I am St. John's Health Center Prostate Nurse Navigator. As a prostate nurse navigator, my role is centered around guiding patients and their loved ones through the complexities of prostate healthcare. I am here to provide patient education and ensuring patients understand every aspect of their diagnosis and treatment options. I also help in allocating resources that best fit your individual needs and assist with managing symptoms to enhance comfort and recovery. I focus on crossing the T's and dotting the I's, meaning I take care of the details to ensure your journey is as smooth as possible. Whether you have questions about your care plan or need support with any aspect of your treatment, I am here to help. My commitment is to ease your way through this process and walk this journey with you, offering support and guidance every step of the way. So with that, tonight, we aim to provide you with comprehensive insights into BPH, or benign prostatic hyperplasia, and explore the innovative treatment approach of aquablation therapy. Throughout this session, you'll gain a deeper understanding of BPH, its symptoms, diagnostic methods, and various treatment options, including the cutting-edge aquablation therapy. Presenting this evening is Dr. Mehran Movassaghi. He is a dedicated urologist and the driving force behind men's health at Providence St. John's Health Center. Because of his passion for integrative care, he founded a pioneering men's health program in Los Angeles. And as president-elect of the American Society of Men's Health, he champions early detection and education along with minimally invasive treatments, all aimed at helping men lead healthier and longer lives. It's truly been a pleasure to work alongside him and witness his commitment to men's health. Here at St. John's, we are deeply committed to caring for our neighbors and their families. We believe in compassionate, patient-centered care that goes beyond just treating illnesses. Our approach is rooted in groundbreaking research, teamwork, and a supportive environment that addresses every facet of well-being: medical, emotional, social, and spiritual. Our high-performing rating means we excel above the national average, and being named Best Regional highlights our top-tier performance across many areas, as recognized by U.S. News and World Report. At St. John's, we're here to make a heartfelt difference in the lives of those we serve. This evening, Dr. Movassaghi will present. Then we'll wrap up with a Q&A. You'll see that many of your questions will be answered during this webinar. For those who had specific questions, we'll answer them during the Q&A. Please use the Q&A option at the bottom of your screen and not the chat. This feature allows you to engage directly with me. I will either answer your questions directly or Dr. Movassaghi will answer it during the live Q&A. If we can't get to your questions, we'll email you the answers. Thank you so much for joining, and I'm now turning it over to Dr. Mehran Movassaghi.
Mr. Fine. Thanks for that excellent introduction. And really, you are one of the special sauces that we have here at St. John's that makes, I think, the journey for our patients throughout this process so much easier and overall such a positive experience. So tonight, we're going to spend a small amount of time talking about what BPH is, how it's diagnosed, some of the options for treatment, and then talk specifically about aquablation and why we have really adopted it so much here at St. John's. So what is benign prostatic hyperplasia? It's benign non-cancerous growth of the prostate. It generally starts in the middle ages, like around age 40, and as men get older, the prostate tends to grow larger, likely as a result of testosterone and changes in testosterone. As men get older, testosterone levels tend to decline. The prostate, utilizing testosterone as a fuel, becomes smarter and tends to react more to testosterone levels, and therefore it grows. BPH is not prostate cancer, and that's a question that a lot of my patients ask all the time. And in fact, it's not even linked to prostate cancer, but we can specifically address that topic later if any questions arise. The prostate itself is a walnut-sized gland, and it plays a role in male sexual function, and it actually produces the majority of seminal fluid. But other than that, its role is limited. So how does BPH affect the bladder and the urethra? Well, I always tell patients that the prostate is essentially the gateway to the bladder. So if you look here on this, this drawing, the normal prostate, the normal bladder, you can see that there's the initial part of the urethra or the urine channel is made by the prostate. And so as the prostate enlarges, as you can go to the picture on the right, it can cause an obstruction. A lot of guys think that the urethra is a tube within the prostate, but in fact the prostate itself creates the urethra in the initial parts of the urethra. And so when you have a growth of prostate tissue, it results in obstruction of the urethra itself. So there's about 40 million men in the US that have BPH, but only about 12 million get actively managed and treated. And a lot of times it's because, most of us guys, when they have a problem, we just assume that it's just normal aging. Or we may or may not go to our primary care doctor once a year. And if they ask about urinary symptoms, we may say, yeah, I don't pee as well as I used to, but that's just how it's supposed to be. That's just part of natural aging. And although that's true, that as we get older, the prostate gets larger, there are certain negative implications related to kind of ignoring the symptoms. If you're getting up more at night, if you're having a harder time starting your stream, if you feel like you have to go to the bathroom even though you just went, these are all signs that your body is telling you, hey, there's something wrong down there. Pay attention. And we'll talk in a second about what can be some of the major negative consequences of delaying care. A lot of guys don't like being on medications. And in fact, 7 million guys that are on medications, a lot of them don't like the side effects related to some of the medical therapies out there. And about 1 million guys delay surgeries because they're worried about the side effects of surgeries. So, up until recently, we haven't really found a perfect or close to perfect solution to try to address some of these issues. What are some of the symptoms related to BPH? Well, I break them up into two subsets. Some are called irritative symptoms and some are called obstructive symptoms. Obstructive symptoms are relatively easy to understand. The prostate gets bigger so that there's an obstruction that occurs at the level of the bladder neck, so it makes it more difficult to pee. So you have a strain to be able to urinate, you have a weak stream, you have stop and go streams or intermittent streams, and you can at the far end of the spectrum get into retention where you actually can't urinate and you have to require a catheter. But the irritative symptoms, which are secondary results of the bladder changing to the obstruction, are more indirectly related to the obstruction, like urinary urgency, frequency, waking up at night, or nocturia, and incontinence. So what happens if we ignore some of the long-term effects of BPH? So you can actually see on this diagram that normal bladder, which is a muscle, looks similar to this. But as the bladder gets more and more diseased, as it has to work harder in order to overcome the obstruction, then the walls become thickened, and eventually the thickened wall becomes fibrotic, and you can also get these outpouchings or trabeculations, as we call them, or even diverticula that result as a result of the bladder damage. And once the bladder is damaged, there's really no way to kind of undo that damage. And that's why some men, as they get older, they ultimately end up needing to use a catheter, or they develop bladder stones because the urine stays in there and all the minerals in the urine calcify and develop into stones. They can get recurrent infections or blood in the urine, and in the rare case, you can also lose your kidneys, because if the urine is unable to go, eventually the urine backs up into the kidneys, and there are some men that have ultimately ended up on dialysis. Although, watchful waiting may be an option, and a lot of times guys are like, this is fine, I'm okay, everything is fine. There are some major medical negative implications that can occur with ignoring the symptoms. So what are some treatment options? So, the easiest thing is, first of all, get diagnosed. And we'll talk about diagnosis in the same. But behavior modification can help. So fluid and diet changes, in other words, trying to limit the amount of fluid that you're intaking, especially at night, can help with nighttime symptoms. A lot of my patients ask, what diet should they follow? Well, the only diet has been shown for both prostate enlargement and prostate cancer to help is the Mediterranean diet. So essentially, unprocessed foods, good fats, good oils, low sugar, and a lot of fruits and vegetables, mostly vegetables. Bladder training is an option where you essentially kind of put your bladder on a time schedule where you're not waiting to have accidents, and you go every 2 hours, even if the bladder's not very full. Again, this is for early stage. And then if that doesn't work, then you go into medical therapy most of the time. And we have a few different options in terms of medical therapy. We have medications that can help you pee easier. These are called alpha blockers. So a lot of the common ones are tamsulosin or Flomax, alfuzosin, silodosin, finasteride, and its sister medication, dutasteride or Avodart, can help shrink the prostate. Again, not every patient is a candidate for this, and there are certainly some sexual side effects that can occur. And then most recently, in the last 20 years, we've been utilizing tadalafil or Cialis that can help relax smooth muscle throughout the urinary tract as an option for treatment. And a lot of times we have to use combination therapy. And for men that have a lot of irritative symptoms, some of these medications don't work. So we have to give medications specifically for the bladder. In 2025, we have a large group of surgical techniques that are available. And in fact, I do most of these, but I really have shied away from doing some as a result of the ability for Aquablation to kind of fit the needs for a lot of my patients. And I won't get into many of these, but quickly I'll review what these are. A UroLift is using metal clips that can help kind of open up the prostatic urethra, similar to kind of opening up the curtain. It's usually uses 4 to 6 clips. I used to do a lot of these in the last 5 years, but as we've seen the results over the last couple of years, we see that a lot of these UroLift clips fail. A lot of them can become calcified and result in bladder stones. So it's become essentially kind of something that I shy away from unless very specific cases. Optilume is a medicated balloon dilation of the prostate that can help in certain cases of smaller prostates to help open up the prostatic urethra. Resume will use steam to help open up the urethra, but again, it's usually for smaller prostates. iTind is using a temporary prostatic stent that can help create an indentation in the prostatic urethra to allow for better voiding function. A TURP has always been the gold standard of prostate surgery. It's essentially removing parts of the prostate, the part that's surrounding the urethra, to help open up and create a larger channel. Aquablation is a kind of a cousin to the TURP in the sense that it also does a similar end result. However, instead of using electrosurgical loops, we use water in order to be able to create a larger, more exact channel. And in cases of extreme prostate size, like over 300 grams or so, a simple prostatectomy or removal of all the adenoma or the benign growth of the prostate, nowadays usually robotically, is performed. So over the last 3 years, St. John's has essentially become a center of excellence for Aquablation. I think the reason is, in my practice, and of the 350, I think I've done about 230 now, but when these slides were made, to today, I think I was told 227. That being said, is because we see very good results in terms of long-lasting results where the patients have great streams. Both their irritative and their obstructive symptoms are treated. They have very minimal side effects, including preservation of sexual function. And in terms of recovery, we will talk to my patients who just had the procedure a couple months ago, but most patients are back to their baseline within a couple weeks. And because of that, we really have adopted this technology and really become a huge proponent for Aquablation. For essentially most prostates, greater than 30 grams. So what is aquablation? Aquablation is using water jet therapy to help create a channel throughout in the urethra. Some of the key factors that set aquablation apart from other treatment options, specifically TURP, is that 99% of men preserve erectile and orgasmic function. 89% of men preserve ejaculatory function with aquablation therapy. There's essentially no one that I have in my cohort that has developed any incontinence, although sometimes irritation of the bladder can occur, and that takes some time to heal. And in the studies that have been done thus far, 94% of men that undergo aquablation don't require any additional treatment with medications or surgeries at 5 years. So, the studies are ongoing. So how is aquablation done and how is it different? Well, it's a robotic arm, and this is the robotic arm that you can see on the screen that's inserted through the urethra. And then in real time, we use an ultrasound probe that's inserted into the rectum in order to be able to plan how deep the robotic arm is able to penetrate into the prostate and create a channel. And this is all done through using saline. So I usually tell patients it's kind of like power washing your prostate, but obviously done in a very exact and precise manner. So here's a video, and you can see it's kind of if we could take a side profile where this is the prostate, this is the bladder, and so the robotic arm is inserted into the urethra, and at the end of the robotic arm is where these the water the water channel is utilized to create the opening. And then at the same time, you could see down here on the screen, we have the real-time ultrasound that is used for planning how deep the cuts are made, and we avoid any of the critical structures, including the bladder neck and the ejaculatory duct that sits right here. And so you can see in this, animation and also in real time how the water jets are creating kind of a windshield wiper effect where it's opening up the prostatic tissue. And this is what it looks like in real time. That's water that's being sprouted out into the tissue and creating that open channel. And because of the fact that we can plan exactly where the resection is taking place, we can spare the ejaculatory duct. That's why we have a greater than 90% preservation of ejaculation, and also the bladder neck, so you don't get retrograde or backward flow of ejaculate. Okay, and with that, we want to spend the majority of the time answering questions. All right, so we'll start with these. These came directly from the audience, and if there's more, we'll add them if there's time. So I've heard that enlarged prostate mean that it grows inward versus growing larger on the outside. Would like to know more about this and how this is detected. All right, that's a great question. So yes, an enlarged prostate can mean both, not just growth outward, but growth inward as well. It's the inward growth that usually results in symptoms. And it's very important, when a guy comes to me and they're like, well, my GP did a prostate check and they said it's a little big, but, or they said it's normal. So why do we have to do any more testing? Well, first of all, the rectal exam can only give you about a 20% accuracy in terms of prostate size. So in general, I always recommend that we do a prostate ultrasound in order to assess the true size of the prostate. Now, an ultrasound can give you the picture of the prostate from the overall size, but it can't tell you how obstructive a prostate is internally. So that's done through a procedure called cystoscopy. And if someone is ready to go to the next step in terms of surgical care, that's one of the things that I recommend. And we usually do it before we plan for any surgery. Hopefully that answered your question. Does aquablation therapy cause loss of ejaculations? So like the other surgical procedures like a HOLEP, which is holmium laser ablation of the prostate, or TURP that has about a 50% chance of retrograde or loss of ejaculation, or a simple prostatectomy, aquablation only causes loss of ejaculation in 10% of the patients that undergo it. And this is because when we're planning for the prostate procedure, we can spare the bladder neck and also spare the ejaculatory duct. So yes, but much less than the other procedures. Is the procedure applicable to patients that have had prior BPH surgeries? Yes. In fact, some of the patients that have had a urolift in the past ultimately end up needing an aquablation because those clips have become calcified. If they've had TURP more than 10 years, sometimes the prostate regrows and they'll need retreatment. If they've had microwave surgery, especially in the 90s, that was very popular. If they'd had any of the other procedures that we talked about, generally, yes, they can undergo aquablation. Does having the procedure help prevent kidney stones? Yes and no. So if you have urinary retention and you're not completely emptying your bladder, that can lead to urinary stasis, and that can lead to kidney stones and bladder stones. But if you don't have any sort of urinary stasis, then this is probably not going to help you. Does Medicare cover this procedure? Yes, Medicare does. And some of the Medicare Advantage plans require a prior authorization, but we generally are able to get coverage for most of our patients. How is prosтрatitis relates to sexual health in advanced age? Techniques for reducing the former and improving the latter. So in general, if an enlarged prostate doesn't directly correlate to sexual health, however, I do have patients that have reported improvement in their ejaculation and even in their erections after they undergo aquablation. And some of that may be just from confinement of the urethra, that now they're able to ejaculate better now that there's an open channel. But in terms of directly improving erections, no direct correlation. And I think to improve ED, that's a whole topic on itself relating to hormonal optimization, medications that can help with blood flow, and newer techniques like shockwave therapy, radiofrequency therapy, and so on. So I'm happy to answer that offline. What causes urgency and frequency of urination? So that's what we consider an irritative symptom, and it's when the bladder is reacting to the obstruction, and so the nerves that innervating the bladder, become overly active, and so then you feel like you have to go to the bathroom all the time because you're not able to completely empty. Or sometimes it's related to a growth of the prostate into the bladder called a median or middle lobe. And so the bladder doesn't know that's a piece of tissue in there. It thinks it's urine, so it keeps trying to evacuate that. How long can aquablation be expected to last before it needs to be redone? So the studies, like I said, 94% no retreatment at 5 years. But generally speaking, it depends on how big your prostate is to begin with. If you have a 60-gram prostate, I would expect that the aquablation can last for 10 years or more. If you have a 160-gram prostate, then you may need retreatment at 5 years. How common is bladder neck contracture after aquablation, and is there ever a point where we need to be concerned with its occurrence? So of the 227, I've had one patient that's developed a bladder neck contracture, and in general, it's a very uncommon side effect, because generally we don't use a lot of electrical heat energy, which can lead to the scarring. But has it been reported? Yes. The most important thing related to when you need to be concerned is if you notice a significant change in your flow after the surgery. So, you were going fine and good flow, good emptying, but then all of a sudden 6 months later, 12 months later, you have a significant reduction. What are your thoughts on prescribing Proscar, finasteride in lieu of opting for ablation surgery. Well, I have absolutely no qualms with that. In fact, some patients opt to do medical therapy for the rest of their life. So it's just a matter of one, patient preference, and whether or not the medications are effective. So if we follow the patients for 6 months, 12 months, 24 months on medical therapy, and they're progressing in both symptoms or the amount of urine that's left over in their bladder, we call that post-void residual after they pee, then, surgery should be seriously considered. But at the end of the day, I respect my patients' personal opinions. It's their body, it's their temple, so I would never force anything on any of them. Cancer versus BPH. So cancer usually is very different in BPH in both where it occurs and some of the symptoms. Cancer has no symptoms. In fact, that's why we use screening tools like PSA tests and prostate MRIs to help detect prostate cancer. That's why digital rectal exams are still considered important, because cancer usually is on the outer edge of the prostate versus the inner lining of the prostate. And BPH has all those symptoms that we talked about. And I have a lot of patients that come in saying, I think I have cancer because I have all these symptoms, and it's usually just BPH. I had a urolift. Are the clips removed as part of the aquablating process, or are there any other considerations? So yes, the clips are removed, but the clips that are placed during during a urolift, there's an internal clip inside the urethra, and there's an external clip that goes on the outer edge of the prostate beyond the capsule. Usually those clips are permanent and they cannot be removed unless they're misplaced and they're lodged out during the procedure. Okay, what preparation is needed before the procedure, and what should a patient accept for recovery after? Okay. So preparation in my clinic is, one, we do an ultrasound, we do a cystoscopy to evaluate if you're a good candidate and determine what should we expect after the procedure. If you have a very late stage bladder, then some of the irritative symptoms may still require more treatment even after the procedure. Then you need to see your primary doctor for a pre-op evaluation. And then every one of my patients, generally, we prep them with a couple days of antibiotics before the procedure and a light bowel prep the night before the procedure. Does this require general anesthesia or lighter? No, this requires general or at least spinal, but in general, I recommend general anesthesia because remember, the robot is power washing the prostate at up to 10,000 psi. So we cannot have any movement because there's a lot of important anatomical landmarks that we do not want to go beyond, because that can lead into a lot of complications. What does the recovery process typically look like? So patients spend the night in the hospital, they have a catheter overnight. About 10 to 20% of patients will go home with a catheter, but the overwhelming majority, 80%, go home catheter free. We do a voiding trial the morning after the procedure to make sure patients are able to urinate. What's typical in terms of symptoms after the procedure: blood in the urine, urgency, frequency. It's kind of similar to having a urinary tract infection, and some urethral irritation and burning. But those generally go away within anywhere from, like some of the patients told you, 2 to 3 days to 2 to 3 weeks. And that's your typical kind of recovery. What are the main risks associated and warning signs should prompt a call? Okay, so the main risks: infection, bleeding, and damage to any of the surrounding organs. So in terms of, infection, we make sure you don't have an infection at the time of the procedure. We give you preventive antibiotics. And in terms of the developing an infection, the risks are very low. I would say less than 1%. As far as bleeding, when after the procedure we remove the Aquablate or the Aqua Beam, the robot, I go back in with a camera and I do fulgurate any bleeders. So we make sure that there's no bleeding at the end of the case. But I do have patients that have been on blood thinners in the past that have, had a delayed bleed. And so the warning signs are, if you go home and you look at the toilet and it's full of blood, then you come back. And, again, the 230 or so, I've taken back, I think, 3 or 4 patients for bleeding. And that's, very low risk, but nonetheless, that is a serious complication. And as far as other things in damage to surrounding organs, obviously you can damage the bladder, you can damage the urethra, which can result in scarring. A lot of times, urethral scarring is a result of a narrow urethral opening, and those can be identified at the time of the procedure. And I usually tell patients if this becomes a problem, there's a lot of good solutions for it. Is this an invasive procedure? Yes. By virtue of putting a camera in both the urethra and an ultrasound. But as far as any external cuts, any cutting the skin or anything, no. Nature, description, risks, I think we got into that. So TURP, comparative advantage. So a few things. One, TURP, you're kind of going blindly. There's no mapping, there's no ultrasound that's going to be able to help determine how deep you're going to go. And you kind of just go until you reach the prostatic capsule and and so depending on how good of a TURPist you are, this may take an hour, it may take 4. So in general, because of the water jets and the robotic arm, the OR time is a fraction of what a comparable TURP would be. In terms of sexual function, the fact that we're using very minimal cauterization, we're able to make sure that the nerves that are on the outer edge of the prostate that control erections are not damaged. And we can also plan for saving the ejaculatory duct and the bladder neck that are responsible for ejaculation and normal ejaculatory function. If you have a successful aquablation and 5 to 10 years the prostate grows back, can you have it a second time? Yes, absolutely, unless there's any other contraindications. But in general, not a lot of contraindications. Okay, with that, I think we answered everybody. What I would say to everyone that's on this webinar tonight and listening is I don't want to scare you, but at the same time, just don't ignore the signs that your body is telling you. And I'm glad, Jeff, you had a good experience. I'm glad we were able to take care of you quickly. And thank you for joining us tonight. My favorite thing to tell my patients after they do the aquablation is, how does it feel to be peeing like you're 20? And, it's one of the things that as a urologist brings me a little bit of joy. I'm sure my kids would make fun of that for me, but it's okay. All right. Well, thanks, John. Your story is not as dramatic, but it's also a lot more common, right? So you had some symptoms, and you talked to your doctor, and they made the referral, and here you are. And that's the key. Again, just listen to your body, talk to your doctors. And I'll be honest, some doctors may not even know what aquablation is. I think the ones in our community, because I've done so many, are becoming more familiar. But the fact that you're here, sometimes you can educate your doctors. And you should really go to someone that does a lot. You don't have to come to me, but you should just ask, how many have you done? Because there is, an importance of getting better with experience. And we are right around time. Do we have any more questions, Ro? We're good. Okay, great. So Jeff, John, Ro, thank you guys so much. Thank you, St. John's, for helping sponsor this and putting this on. And as far as, getting in touch with me or reaching out, we're going to send a follow-up email, all right, to all the participants in the webinar. Thanks, you guys, again. Take care.